Welcome to True Health Tuesday, and the truth will set you free. Today we're talking about scoliosis, which is hugely important. So when we look at a normal spine, we should be straight. Where we're standing up from the side, we need these curves. And the curves are actually built in the spine for shock absorbing. Now, if you don't have those curves, and what you're going to see in scoliosis typically is there's going to be a loss of the normal cervical, lordotic curve, and lumbar curve, and thoracic curve. So the body develops these lateral deviations for that shock absorbing. But also, ligaments are 2.5 times more flexible than normal in people with scoliosis. And a lot of times, scoliosis is misdiagnosed. It has to be over 15 degrees. Beyond that, it's going to be a traumatically induced buckling. So what causes scoliosis? Trauma, long-term chronic stress, malformed vertebrae, and literally a change in proprioception of how the brain views the body and space. So let's see, how do you know that a scoliosis can be corrected, or if it can't? Number one, you've got to take a static x-ray where the person's standing up weight bearing, and then you're going to bend them in to that convexity. Now, all you're doing there, you're just seeing what the limit of the structures are involved. Even though the disc can change shape, the ligaments can change shape, the muscles can change, all of that over time, pressure over time. But right now, we're just seeing what that body can do. Now, if you bend it and it doesn't change, then it's static. It's not going to digress or progress. If you do bend it and it does change, that's the minimal amount of correction possible. So here we have a patient with a 32.4 degree bend or curve. And when we bend her, it bends down to 9 degrees. Now, even with the osteophyte formation, and you can see that it's almost a flowing candle wax of bone, but that osteophyte is trying to stabilize an unstable segment. So even with that osteophyte formation, that's 32 degrees, 32.4, down to 9.1 degrees, that's the minimal amount of correction, not maximum, minimal amount. Now, here's a patient, we're going to call her Mary, 25-year-old. She had a 24.6 degree curve at the top of the thoracic area. Now, when we bent it, and you really have to do almost like a dance move to drop the shoulder down, bend the head, and torque it out as much as you can. And she went from 24.6 down to 18.5. Well, on the post x-ray, it was down to 15.5. So what do you got to do? You got to do another bend. Now it bent down to 12.1 degrees. So that's the new goal. So you continue going on this pathway of getting a baseline, seeing the minimal amount of correction, and then doing a post x-ray to document what's changed. And if it does change, then you bend it further to see what a new goal would be. So her original from that 24 degrees down to 12. Now here's a 4-year-old child with hemivertebrae. Vertebrae are supposed to be square. In some congenital anomalies where the body, when it's forming, it didn't form correctly, she had a number of wedge-shaped vertebrae, and I'm talking T8, 9, and 10 are abnormal, and L1, 2, and 3 are abnormal. Now, the tough part with this is obviously the surgeon wanted to put a steel rod, but in a 4-year-old child, that's really hard because the child's going to grow and steel doesn't. And they have all sorts of bells and whistles. But this kid has got some big challenges. But how do you say, even in this 4-year-old child, if you can help them? For one, when you're looking at the static standing x-rays of her, you can see that she has an abnormal bowel gas pattern or a leaky gut. And that's, again, you can't not address the scoliosis with just the vertebrae, muscles, and bones. You've got to look at proprioception. You've got to look at how the body can regenerate tissue. So you've got to address every aspect with this kid. So in the middle, we're looking at the upper curve, and we can see that there's some hemivertebrae, wedge shape, some missing pedicles. I mean, a lot of issues. And then we look at the lumbar area, again, the same thing, a lot of congenital anomalies. So the upper curve, when we bend her over to the right, and this is the patient facing us, so even though they're bending to the left on the film, they're actually facing us. We can see that even though the hemivertebrae are there, the curve still reduces. And in the lumbar, when we bend that curve also changes. Now, the hemivertebrae aren't moving that much. They are moving some, but the area above and below are hugely important that we can do it. Now, after just about 2 weeks of working on this kid, her pain went away. She was able to run, jump, play, bend, turn, twist, and thank you, God, they canceled the operation. Now, when you look at spinal bracing, I'm not a big fan of this, and this is the number one option. Why is this ineffective? Well, for one, the brace relaxes the muscles, and you got to look at the muscles on the convex or the outside portion of the curve are spasming out to correct the spine. And it's not that the muscles are inside of the curve or the concavity that are creating that. It has to do with proprioception. And the bracing does not help with proprioception or the brain's view of the body in space. When the brace is removed, the muscles can't support the spine and the scoliosis worsens. I'm not a big fan of the surgical brace or the brace. Now, the spinal surgery, again, this doesn't address the proprioception. It rarely, if ever, restores the natural curves. Surgical fusion prevents normal movement of the spine, which causes hypermobility of the non-fused segments, the area above and below the surgery site, and the number of negatives. When you fuse the spine, you stop movement, and the brain needs that movement for an energy. And after this person's surgery, before the surgery, she could carry a bag of concrete across a yard, only a 60-pound bag, not a 90-pound bag. After the surgery, within about a year, her hands started to move because that's the brain wanting to get more information up to it. Now, the risks of back surgery are great. You can have a risk of a reaction to the anesthesia, which can impair brain function, bleeding, infection, blood clots, and we're talking in the legs and lungs, heart attack, stroke, recurrent disc herniations, nerve damage, bowel and bladder control problems. There's a lot. Now, only through specific chiropractic techniques can scoliosis be corrected. Now, not all chiropractors are the same, obviously, and not all schools are the same. Now, less than 10% of the chiropractors specialize in structural correction. You must thoroughly research your chiropractor to find out if they specialize in correction. We have 7 questions, and it doesn't mean that if the chiropractor says yes to 5 of the 7s, because that's what I say, just lower the bar. But let's look at basic common sense. Number 1, do you take x-rays? Now, if they're taking them just because they could bill insurance and they're not utilizing for care, again, that's basic. But do you utilize the x-rays or get listings off the x-rays to guide your care? That's key. And then do you take post x-rays to document the structural changes that you've made? That's the key. If you're going to someone that took one set of x-rays and you never take another set, did they fix it? Did they not fix it? And then what are the treatment goals of the doctor? A lot of doctors just want to get you out of pain, and pain is not the problem. Pain is an alarm telling you there is a problem. And so you need an objective analysis, an object to look at. Now, we do nerve scans, we do post x-rays, pre and post nerve scans, pre and post x-rays, thermography, pre and post blood analysis, everything. Now, are you familiar with correcting disc injuries? If they are a good chiropractor, they will be familiar with that discs are alive and they can regenerate. Do you work on post-surgical patients, which is hugely important? The failure rate, they even had a billing code called failed back surgery syndrome, that you have to work on these people that have been subjected to surgery. And can you reverse arthritis? If you're doing pre and post x-rays, you will see discs regenerate, and you will see bone spurs be resorbed in the body. It's called Wolff's Law. Bones lay down where it's needed, resorb where it's not. Now, there's a number of good techniques, and this is only a small part of them. And every school is different. A lot of schools only teach what's called diversified, but a lot of other schools teach different specialties. And then there's seminars all over the place. I mean, Gonstead is fantastic. Thompson drop technique, I utilize both of those. Sacral occipital technique, I use parts of that. Chiropractic biophysics, CBP, brilliant. We're talking one of the most researched techniques out there. It's fantastic. Full spine specific. This is one of the courses that I taught and assisted this master, Dr. Jacobson at Cleveland Chiropractic. I mean, he was he will always be in my heart. And Cox flexion distraction technique. Now, I literally utilize every one of these techniques along with a couple of upper cervical ones. Now, red flags to watch out for techniques. And I don't recommend going to a chiropractor that's going to really twist and torque the spine and then get an adjustment. I mean, they're going to get a pop. They may help in symptom relief, but you're not going to get a neurologic correction. And watch rotating the neck. We turn the neck no more than 10 to 15 degrees. Some doctors will turn the neck far, lock it out, and then adjust. You're not going to get a good correction. Look for lateral flexion of the spine. You don't want to do that. Hyperextension and lateral flexion. I don't like the decompression machines because the body, when you're just stretching it or decompressing it, there's always going to be some lateral deviation. We do spinal decompression with hands, not with the machines. And in non-specific cracks, the crack that you hear during the adjustment is pressure building up and pressure releasing. That is not the adjustment. The adjustment is to change the position, motion, and communication to the brain. And you don't want to relax or massage the muscles, particularly in scoliosis. The muscles that are spasming are always on the convexity, and they're correcting the problem. So what's the goal of the chiropractic adjustment? Well, number one is to create a local inflammatory response at the level of the disc. And then to change that proprioceptive influence, because around each vertebrae, you have joint mechanoreceptors that communicate to the brain. You've got 4 times the amount of muscle spindle receptors in the small intrinsic muscles of the spine, and even the ligaments have sensory components. So you want all of those components to communicate to that brain so it balances out the paravertebrals, the muscles on either side of the spine. You need to change the biomechanics of the pelvis and extremities. On every patient with scoliosis, we have to pay attention to the arch of the feet. We've got to eliminate bunion formation. We've got to restore the biomechanics of the hips. We've got to stabilize the pelvis. So you have to look at the entire structure. And you are changing the position and motion of each specific vertebrae. And look at that communication. Your goal is to improve the overall structure of the spine, to reverse degeneration and arthritis. If those joints are still mobile, and doing pre and post x-rays, you'll see that. To rehydrate and restore the intervertebral disc, because discs get their nutrients through movement, and to alleviate pressure on the spinal cord and nerves. And it's literally improves that nervous system communication. Your brain sends 1 billion impulses a second down. That means it receives that so it can adapt to the environment. Correction of scoliosis is not just done by causing an inflammatory response at the level of the disc. Correction is mainly done by changing proprioceptive firing. And all these adjustments are vital for the patient's proprioceptive response. This is why in between the adjustments, we are literally giving that patient cross-crawl exercises. Now, a stimulation of proprioception, and this is the key. When we're adjusting someone, we do the same force loading in the prone, side posture, and supine position. And this way, we're separating the adjustments by 90 minutes, and they're doing the cross-crawl exercises. So the x-rays are a guide, but how that body is responding in between each adjustment is going to be the key. And this is why we do the same force loading in the prone, side posture, and supine, which literally changes that brain's awareness of the body. And you'll see here, thoracic, I'm doing in the prone, providing a lateral to medial torque. In the side posture, lateral to medial torque. And in the supine position, my hand is underneath her left shoulder, and applying a force loading in that position. So that is the key to change proprioception. Vibratory therapy. Now, this is huge. It's important, along with all the adjustments, several exercises, stretches. Now, combined, this vibratory therapy improves the speed and quality correction. Now, the vibratory device needs to be about 10 cycles a second or less, which is important because a lot of vibrators out there are very, very high frequency. And I want to get deep because when you're vibrating the back, you're going to loosen up the ligaments, which is the disc, which is about 2 inches deep. So you want a deep, heavy, slow vibration to allow that disc to start to loosen up so you can start to move it. If the cycle is too high or too great of a frequency, you can overstimulate the nervous system, and this negatively affects proprioception. And a high cycle threshold can also relax the muscles too much, which negatively affects the structural correction. Now, I've modified a jigsaw variable speed, and it's slow, deep, and easy and effective. It's fantastic. Now, the vibratory should only be done on the concave portion for about 5 to 10 seconds. Now, when you're vibrating, palpate the muscles on the convexity. And while you're vibrating, you're going to feel the muscles fluctuate just a little bit. And it's almost just like a little muscle reaction. But that's why my hand is flat when I'm doing the vibration, so I can feel that fluctuation. And that means that you've changed some of the structures that are going to change that communication to the brain, and then that changes the brain's control of those paravertebrals. And that fluctuation means that you can now get in there and do the traction, do the adjusting, and you're going to have the best chance of changing proprioception. Now, in severe scoliosis cases, you may need to do a meningeal release, which is a little bit different line of drive than normal. But that thoracic area, the meninges, can get bound up. And to release that allows for more normal motion, but it also allows for that nerve flow to flow down and the sensory input to flow back up. And the line of drive will always be from the convexity to the concavity. Now, for chiropractors, gentlemen, ladies, you have got to get a drop table. The force is mass times acceleration. With a drop table, you don't need to push that hard. You're going to be able to generate a force, and it's going to be easier on the patient, easier on you. And the key is to keep the spine in neutral at all times. Never torque or twist or bend or turn that spine, because when you do, you're triggering all of the sensory component of those vertebrae into the brain, and that's going to not allow you to change that brain's view of the body. Your goal is to change the position and motion of that vertebrae and that communication to the brain. And you can adjust the patient multiple times a day. Now, separate each session by 90 minutes because the body works on 90-minute cycles. This will help get an incredibly fast structural, biomechanical changes in a short period of time. I recommend having them walk barefoot in the grass with symmetrical actions or symmetrical movements. We also have patients sit on a bench with ankle weights, and they swing their legs, again, in symmetrical action by tapping something like the back of a chair. And those things work fantastically well. Now, the exercises for the scoliosis in the thoracic area. Now, what I recommend is a firm foam piece or rolled up towel, but it has to be very, very firm, about 4 inches in diameter, and have the patient lay on their side right at the apex. But when they're laying on their side, you want the spine in a neutral position. So if they're laying on a right thoracic scoliosis, you want pillows to support their head. You want a pillow in between their legs so the pelvis isn't strained. The patient will initially find this uncomfortable, but have them deep breathe. This is the key. Deep breathing during that force loading exercise increases the intrathecal pressure, and it helps hydrate those discs. And typically within 3 to 4 deep breaths, and have them breathe in through the nose, out through the mouth, diaphragm's moving up and down, so the tummy's moving up and down, or in and out. And this will hydrate those discs, and it is amazing in how fast they'll notice a difference. Now, start the patient off, 3 to 4 minutes in the ballpark, but you want to get them on that for 18 minutes. This lateral force loading will change the firing of the mechanoreceptors and change the tone of the paravertebrals. Why 18 minutes? If you look at the plastic elastic deformation curve of human tissue, anytime you put human tissue under pressure for 18 minutes, okay, then you've affected the change. Now, combine this exercise with regular frequent adjustments, and this will produce major structural changes very, very quickly. This is one of the easiest and best complied with exercises. Yeah, patients actually like this one. Young children, young people with scoliosis curve. Well, one of the things I tell patients, okay, is, okay, buddy, you got to watch at least 20 minutes of TV a day when you're laying on this. And they're looking like, really? I have to watch TV? Yeah. Now, here's a great exercise for scoliosis. Now, imagine, okay, if you have a right thoracic scoliosis, we're going to use the scapula. So with the arm tight to the side, put it up against a wall and take a slight step forward. And that's going to force that thoracic area off to the side and make a huge difference. And they hold it for 2 to 3 to 4 minutes, 3 to 4 times a day, in a very, very simple exercise. If you're looking at an upper thoracic scoliosis, very high, and we're talking like T1, T2, their arm can be way up high and they take a step forward. If it's a little bit lower, okay, such as T3 to T6, their arm will be bent up to 90 degrees. And then again, they take a step forward. Not huge amount of force, but just a little bit. And that little bit of force loading there will also change the sensory input. You're going to move the vertebrae just a little bit, and it changes that proprioception. They can even sit with their arm on the couch, and I'll guide them through this, or their arm on the back of a car chair, if they're driving. So there's a lot of different ways you can work this into the lifestyle to make it really easy, but it has to be specific to that patient's case. You can't just do a right or left upper thoracic or lower thoracic curve and use this exercise. It has to be directed by the x-rays and by the chiropractor. Now, to rehydrate and regenerate exercise, this exercise is amazing. Okay, it involves, this is a different one, the twisting of the spine to rehydrate. And what I'll have patients do is put their feet wider than shoulder width apart, lock their fingers, and then twist as far as they can, throwing their arms off to the side, So you're getting a snap in the back. Now, this one I demonstrate in the office directly to the patients. All my doctors do, because if you do it correctly, you're going to hydrate all of the discs. Now, there's 3 ranges of motion that a human being has. Active, that's as far as you can move it. Passive, which is way further. The paraphysiologic range is beyond that, but you're only there for a fraction of a second. And that is where chiropractors live. So if we can get an exercise that the patient is in that paraphysiologic range of motion, even just for a moment, you're going to start to affect a radical change and a radical hydration of not just the lumbar, but also the thoracic area as well. Now, contraindications for this would be post-spinal surgery, some congenital fusions, anomalies, because this puts a tremendous force load down the spine. That's why the big caveat, do not do this unless you're directed by a doctor that knows the purpose of this. And that's all of my docs. I got the greatest docs in the world. And have their patient stand with their feet wider than shoulder width apart, interlock their fingers, rapidly turn so you get the stop on one side, rapidly turn to the other side. There's a powerful torquing effect that is also great for good brain function, like if you're feeling fatigued in the afternoon, fantastic to get more sensory input into the brain. And yeah, it helps to act like they're going to elbow someone in the face behind them. And I always say, once you get this exercise down, you're safe with walking across parking lots. And feet, knees, pelvis need to be locked in place. So you're pointing front the entire time. That way you're isolating the spine. Now, And this exercise, 100 a day. And it's excellent to do throughout the day for people that sit for a long time. I've got a couple of videos on this already that you can get more detail to it. But this exercise doesn't just hydrate the discs. It stimulates that proprioceptor response by opening and closing the facets. So massive input into the brain, and it gets the brain more aware of the body. Now, this exercise is useful for post-stroke, people with balance issues, scoliosis, or buckling of the spine. But again, it's got to be directed. You cannot do this on your own. Got to be directed by a doctor that knows the purpose of it. Sitting, let's turn sitting into therapy. You can use a rolled up towel, water, a plastic water bottle, aluminum water bottle, but where it's going to be placed is the bottom of the elbow is the bottom of the roll. And that means that it's placed horizontally at the junction of the lumbar and thoracic area. Now it's going to be placed back there for 20 minutes, take it out for 10 minutes, 20 minutes in, 10 minutes out. Because remember, in scoliosis, the sideways bends are there, but the normal lordotic curves are generally missing. So this is why we give cervical extension exercises and lumbar, because if you correct that normal lordotic curve, you're going to start to decrease that lateral deviation. But this, if you're, flying across the country, 20 minutes in, 10 minutes out for 5 or 6 hours. Now, this exercise repositions and takes pressure off the thoracic and cervical spine and lumbar spine. And it's going to be 20 minutes in, 10 minutes out. And that forcing in is equally as important as the force off, because you're forcing the hydration of those discs. Now, this should be done the entire time you're sitting. That means we're going to turn sitting into therapy. That means every office worker, pilot, trucker, engineer, everybody that's going to be using that 20 minutes in, 10 minutes out. And the greatest thing is it's literally an exercise you can do throughout the day, and extremely, extremely effective in disc injuries and correcting scoliosis. Also, stabilizing the pelvis, hugely important. When you're looking at stabilizing the pelvis, there's no muscle that crosses the posterior aspect. And in scoliosis, people typically have ligaments 2.5 times more flexible than normal. Also, with the altered mechanics, they're utilizing the pelvis more than it should. So a trochanter support is going to be essential to help stabilize that pelvis. Or they can sit backwards in a chair like a cowboy or cowgirl. And that, moving the legs out, approximates that pelvis and takes all the pressure off of it. Now, how much correction can be achieved? It really depends. Each case is different. That's why when you get a static x-ray and a bending film, then you can have a good idea at the goal. If there is no malformation and no surgery has been done, then it's likely a good correction and restoration can be achieved. How much? Full correction? Possible. Partial correction? Possible. But it's all going to be done on an objective analysis utilizing that. And you've got to find a chiropractor that specializes in some kind of corrective technique. And they've got to properly analyze and document the changes. This is one case. A kid was referred to me for a scoliosis. And this was their picture the before. And I'm going, wait a second. Their pelvis isn't that off. Okay. And it turned out that she had a knee injury and took all of her films at the pediatrician's office with the leg bent. And so you can see, don't let your doctor get fooled. I've had hundreds and hundreds of people come to me that say, oh yeah, I have a scoliosis, and it's not there. 20-degree buckling down to 2-degree. All right. It's just at any age, understand that traumatic buckling and scoliosis can be it can affect your entire world. So it's not just symptoms. When you're looking at a 19-degree down to 12-degree, and you're looking at significant osteophyte formation, you're looking at a bunch of issues there. Short leg by about 1.5 inches. I mean, this is a big deal. And even this person got corrections. Now, what if you've already had a surgical fusion? There is still hope for a positive change in your spinal, your overall health, even if you've had a spinal surgery. Now, here's a patient, before and after, and you can see the evidence of the steel rods. And look at the proprioception, how far over his head was. Okay. And then the correction afterwards. And you cannot work on the surgery site, it's steel bars. But the area above and below, you could restore the curve. That will eliminate some of the lateral deviations. There's always something you can do. There's a patient who, the surgeon did put steel where they shouldn't have. And you could see her steel rods go all the way up into the top of the neck. And there was just not any reason. Now, when they put the steel rods in the thoracic area, they typically have to chisel away some of the bones. So they do a laminectomy generally. And so they cannot remove the bolts and screws from the thoracic area because there's just not the support. But I sent her back to the surgeon, and this is all the hardware she had removed out of her body, which, he did have to put in some more steel rods in her because of the surgical removal of the bones. But hopefully we can avoid this stuff in the future. Here's a sweet gal, 8 years after car accident, and you can see the steel plates in her neck. And then again, here's before and after. Now, even paraplegic with compromised nerve and a post-surgery in the neck, you're looking at 62 degrees down to 53. Why? Because you're getting that brain's communication to the tissue. Even if there's not a conscious control of the brain to the body, such as in a paraplegic or quadriplegic, you can still get good results. Just know that you have to address every aspect. Hopefully I gave you a lot of points that you can use to guide your chiropractor or to find one. But you've got to look at the nerve supply. The key to scoliosis correction is to change that sensory input into the brain and look at the physical, chemical, emotional stressors. Regular exercise. This means you've got to move your body every day, every joint. Scoliosis, the exercises, every day, baby. Nutrition, you're going to eat like your great-great-grandparents. Healthy, organic, free range. When you're eating animals, if you're eating them, they got to be healthy animals. Sufficient rest, the key to regeneration, and prayer and meditation. Look at every study out there talking, you add prayer, you're going to increase healing. Now, make sure you post your questions and comments down below. And we have to divide them up into two different sections. One that I can put on standard social media, one that has to be done on our private site. Because there's certain words that I can't say in society today. But God bless you all. Know that your body is made and designed to be here. And if you have a challenge like scoliosis, there is hope. Stay healthy, my friends. God bless you all.